me, Lauren. Thank you so much for tuning in to this newest video from me on Speak from the Heart. So I can't believe next month will be a year. It'll be 1 year, like my 1 year Speak from the Heart anniversary. So crazy. But we'll jump right into this video. I wanted to tell you guys a little bit about some of the patients that I treat, some of the techniques that I use and why I use them. And yeah, so I tried to do this as a vlog, but there are just too many interruptions at work and I'm usually back to back. Please ignore my little dying spot on my plant. I propagated this from my bigger monstera plant, and for some reason this one has a birthmark, so we're just gonna, yeah. So let's jump right in. So the first patient I wanted to tell you guys about is a patient I'm seeing with Parkinson's disease. I saw this patient last year with a diagnosis of dysarthria, speech diagnosis of dysarthria. We did LSVT loud because the vocal intensity was reduced. So it really impacted his intelligibility, and he still works, so we definitely wanted to target that. After the 4 weeks of LSVT, he made such great improvement. He felt more confident. It was just really great. 3 months later, he's back to me because he started to regress, most likely due to the degenerative nature of Parkinson's. So right now we're just doing traditional dysarthria therapy. We've been using a pacing board, which I really enjoy. This is the pacing board. I just made it on Microsoft Word. Very simple. And with the pacing board, it helps us to segment the individual syllables when he's producing something as small as a 1-syllable word or something as long as a 5-syllable word. He has a tendency to speak with this festinating rate. It's really increased. He's omitting syllables. So the pacing board has been very helpful. We used it at word level, so he came up with words. We used the pacing board. We use it at phrase and sentence level. And then with paragraph reading and conversational speech, we don't use it consistently, but I have him refer back to it if he's having some type of error. And that has allowed him to really self-monitor, self-correct. I also really like to use a voice recorder because it allows for immediate biofeedback for the patient to self-analyze their productions and also give themselves feedback. It's amazing. And so he's actually almost ready to be discharged in a few weeks. I'm really excited for his progress. We'll be doing some more functional tasks like phone calls. He's doing an oral presentation for myself and other colleagues. And yeah, so he's doing really well. The next patient is a patient I see with Broca's aphasia. So left CBA, very, very characteristic of Broca's. And that's pretty rare because typically there's some type of mixed aphasia or there's some aphasia with coexisting apraxia. So he's just straight aphasia. Severely impaired verbal fluency, severely impaired word retrieval, gets very frustrated when he's trying to, form these sentences. So we've been doing VNest. I posted about VNest on my Instagram and a lot of you guys commented. I love VNest. So VNest is really good because the research shows that it helps to generalize to untrained words and verbs. You're allowing the patient a lot of self-control, and so in this video clip, you can see I'm using a whiteboard. I could not find my cards. I usually use index cards. I could not find them. And so, the patient comes up with agents and patients, and so that goes in the who and the what. You give the patient a verb, and then they kind of come up with these sentences on their own. So they may say, the farmer drives tractor. You ask them questions, so different WH questions. So farmer drives tractor on the farm. You start to expand these utterances, but you're kind of stemming it off of a verb. I really love it. And I'll go a little bit more in depth about that in another video. But I've been using that with him and we've seen some really good improvement. He's now making phone calls independently, and it just warms my heart. I love it. My next patient, muscle tension dysphonia as a result of very severe bronchitis. So she was diagnosed with bronchitis last month, I believe, and her husband said that the cough was so severe that it hurt him to like hear her cough like that. As a result, I believe because of the intensity of her cough, and we all know coughing is very harmful for our vocal folds, I think that that's where the muscle tension dysphonia stemmed from. So muscle tension dysphonia is where there's an excess amount of tension surrounding the vocal folds. So when they go to adduct, there's just all of this tension slamming together, and we don't want that. So her vocal quality is very strained, lots of stridor, to the point where she was almost in tears when she had to talk to me during the evaluation. It was very sad to see her that way, and she works, so she's ready to get back to work. And so what we've been doing are cup bubbles, and I love cup bubbles because everybody loves that term, and it's based off of semi-occluded vocal tract exercises. So narrowing the vocal tract, to relieve the pressure that is occurring here at the level of your vocal folds. So you're phonating, but instead of them slamming together, they're just lightly coming together. I like to think of like feathers touching, you know. I try to give analogies for my patients so they understand, but that's been very helpful. I just evaluated her last week, and so there's not much progress yet, but we are getting some reports of less pain, and that's really good. She really loves them because the bubbles, as you blow into the straw, the bubbles give you a visual representation of the airflow, and she's starting to phonate a little bit better, although it's that tension's still really visible. So another thing we added is circumlaryngeal massage. So that's just a type of massage where you give input to the laryngeal muscles. You start kind of at the level of the hyoid and just kind of work your way down around the thyroid, and just moving those muscles and helping to relieve that tension so they're lengthened, the muscles are lengthened, so that phonation is a little bit easier. And my last patient I wanted to talk about is also a stroke survivor, about 4 months post left CVA. Again, lots of weakness, generalized weakness, hemiparesis, but the tongue-based retraction is pretty much non-existent, or it was. So in outpatient, I don't do modified barium swallow studies. The patient is referred to me. I do a CSC, or a clinical swallow exam. And if you want a video about that, give this a thumbs up or comment. And then I refer for a modified. Most of the time I do because I don't have x-ray vision. How can I see what's going on in the throat? The inpatient SLP performs the MBS. I wish I could. And then the report sent back to me. Sometimes I can actually view the MBS too through our computer system, which is really cool, and I can show that to the patient. But this particular patient, that tongue base, girl, like it was not moving at all. There was no contact to the pharynx, the posterior pharyngeal wall. So there was lots of residue in the vallecula and just generalized pharyngeal residue. She was able to clear it most of the time with a liquid wash, but at times the residue was so thick you could see it just trickling down. And so there was some flash penetration, but she was able to cough, which is really good. And so in therapy, we've been doing effortful swallows. I really love effortful swallows because of the research. It shows that it does help tongue-based contact to the posterior pharyngeal wall. It helps to pull that tongue back so it does retract. It helps to propel that bolus into the pharynx, so we're getting less residue there. And so, you know, unfortunately, I don't have access to SCMG or vital stem. So that's one of the drawbacks. But I tell her, push your tongue, take your tongue tip, your tongue blade, push it as hard as you can against that bumpy part behind your teeth, your alveolar ridge. And I tell her to push and swallow hard. And so I want to see, like I should see that effort. And she does really well with those instructions. I keep it nice and simple. We do 100 of those in a session, 100, okay? And I do all consistencies because my thing is dry swallows are good, but she's older, her mouth gets dry. I think her salivation was impacted by the stroke. A year ago, she had an unrelated bout of pneumonia, aspiration pneumonia. And so I think she's still really anxious from that. We do all consistencies. We do puree, we do solid, we do thin. Because I want to show her you can swallow all of these. You use your effortful swallow so we can get that tongue base moving a little bit more. She's been doing excellent. So there's no overt signs and symptoms of aspiration that I can see, but of course I can only see so much. So she will be having a repeat instrumental assessment in the near future. Another thing I do with her are tongue pullbacks. So I hold the tongue. I don't do many of these because this is not a swallowing exercise. But from doing research, this is a really efficacious exercise for tongue-based retraction, just to make sure that tongue base is moving backwards and making contact with the pharynx. So I hold her tongue with gauze or a glove, and I have her just... So for me, I can feel the base of my tongue hitting my pharynx. Like, I can feel that. And so I asked her, like, can you feel that it feels awkward? It might make you feel like you want to gag. So we only do about 10 or 15 of those, but just as a warm up to get that base of tongue moving and working. She does really well with that. And so I'm really excited to see her progress when we go to instrumental and just see how she does with that. So this was really quick. Okay, because if I went into detail, this video would be 20 minutes, and I know I wouldn't want to watch a 20-minute video. But if you guys have any questions, please leave them down below. You know, interact with me on social media. I'm trying to be more active on my Facebook and also my Instagram. They're both the same name. And I hope this was really helpful. Just a little quick glimpse of what I do, the people that I work with, the techniques that I use as a speech language pathologist in an outpatient rehabilitation setting. So make sure you share this, make sure you like this video, subscribe to my channel if you have not, and I will see you in my next one. Bye.